This Let's Talk About Women's Health series has been brought to you by Tallaght University Hospital. These podcasts have been kindly supported by the Healthy Communities Development section of South Dublin County Partnership. Welcome to our sixth and final episode of this series. I'm Colleen, and on this podcast we're discussing what treatment is available for women who might be struggling with the menopause. To learn more, I'm joined by my colleagues, Consultant Endocrinologist Dr. Ann Behan and Colleen Byrne, an advanced nurse practitioner in women's health. You're both very welcome.
Thank you.
Thank you.
So Ann, can you just tell us, what is the menopause?
It's a really good question, Colleen. I think it's one that drives a lot of people around the bend, because we all expect maybe that there is this finite situation that is the menopause. But it's a process that starts and again, everybody's a little bit different what age it starts for, but on average, it starts in your mid-40s with something called perimenopause. And that can lead to fluctuations in hormones with still having regular periods. But the fluctuations can be a little bit challenging and lead to lots of symptoms that Colleen will mention. Menopause then is technically classed as when you have been through perimenopause and you are now at a point where you have not had a natural period for 12 months. But that's a little bit of a difficult classification, because a lot of women will have started HRT before that and their periods aren't exactly a reliable tracker. So it is a clinical diagnosis. It can be helped with blood tests, but it's a clinical diagnosis. So menopause then is when your ovaries are no longer having any signals, you're not making estrogen on your own, you're not making progesterone, and you might have associated symptoms like hot flushes, no periods. That can essentially be a state that goes on for the rest of your life. Are you going to be symptomatic for the rest of your life? Not necessarily. And it will depend on if you take HRT, how long you take HRT for. That will be decided between you and your doctor or your advanced nurse practitioner. So I'm sure that's as clear as mud now, but essentially it's a process.
That was an excellent explanation. And I've heard people say that they took HRT and then when they stopped taking the HRT, all the symptoms presented maybe in their late 60s, early 70s. Can that happen? It can, unfortunately. So the goal would be to keep people feeling well for as long as possible on the lowest dose of HRT possible to keep symptoms controlled. And whether you continue that beyond your 60s, 70s is a conversation you will have with your doctor. It shouldn't really be done without being enrolled in various screening programs and things like that. And that's just general standard health safety advice. But certainly, from what we know at the moment, HRT long-term in the right setting, monitored in the right way, is quite safe. And Colleen, is it the case that if we took HRT and the symptoms were controlled, is there any chance that when we came off the HRT that the symptoms might be gone? Or can that happen?
Absolutely. For some women, when they tailor off their HRT, they can be asymptomatic then and, live their best life there forward.
And so the symptoms are gone, but as such, menopause is never over. Is that correct?
Absolutely. We are living much, much longer than what we used to do. Women are certainly living into their late 80s, and we want women to be living their best life and continuing in good health.
What I often say to people is what you need depends on the stage in life you're at. So some women can wean off their tablet or patch HRT, but they might always need a little bit of vaginal estrogen, or they might need the help of those non-HRT methods that we discussed. We'll always need bone health. We'll always need general lifestyle health. But at some stage, we will get to the point where we can try coming off the HRT and see how we do. It's always worth a trial. In conjunction with talking to your doctor about it to make sure that you're doing it the right way, because what we don't want happening is somebody stopping, say, their progesterone and continuing their estrogen, because that will put them at risk of a thickened womb lining, which can lead to its own complications. So, if you want to do a trial off HRT to see whether your symptoms have resolved, talk to your doctor about it and see can you wean down with their help.
And Colleen, we spoke there about vaginal dryness. Is that a symptom of menopause, and can you do anything for that?
Absolutely. We have urogenital symptoms as part of our menopause, And there are the localized estrogen that we can insert as a pessary or a cream into our vagina. And this helps with our bladder symptoms as well as our vaginal symptoms. And especially for women where they're very uncomfortable during intercourse. There's also other methods as well as using vaginal moisturizers and also vaginal lubrication. And these are things, that are not very well discussed with women, but I've often brought it up when I was talking to the women in our clinics.
It's good for people to know that that's a very normal symptom of the menopause and not to be ashamed to ask for help.
Absolutely.
Colleen, when do women think they will experience the menopause and what's the reality?
So, Nolene, what we know is there's many phases of the menopause. We start with a premenopause where we're still having regular cycles. Then we phase into our perimenopausal stage, and this is where we start getting hormonal changes, and that comes in and around the age of about 44, 45 years old. And this can last up to maybe 8-10 years before we get to the menopause, which is when our periods have stopped for a full 12 months. Thereafter, 12 months, we are postmenopausal. So our biggest concern is in that perimenopausal stage where women start having symptoms. So women will start feeling maybe hot flashes. They may have irregular periods. It could be more prolonged than what they've had before. It could be shorter cycles or skipping periods. They also can suffer with night sweats and mood changes. They notice that they're a bit more crankier with their children or, very intolerant of things happening in the house. And these are their mood changes that they can not recognise as hormonal changes, but are part of that perimenopausal stage. Then they can also get memory and concentration lacks. This is all through this perimenopausal stage. Women can also suffer with urogenital symptoms, and this would be in the fact that they have vaginal atrophy, and that's where women have lack of estrogen in their vagina, changes in their bladder, and this impacts their life, and they don't associate it with the changes of this perimenopausal stage. They may get joint and muscle stiffness with headaches or sometimes even libido, which is, lack of interest in intercourse.
Thanks. And Lucy-Anne, moving to you, what help is available for some of the menopause symptoms that Colleen mentioned there?
Thank you. Well, I would first say the first thing to do is to see a doctor that you are comfortable with seeing, who maybe is familiar with this area, because the first thing to do is to make sure that this is menopause or perimenopause and not something else. And then once you have that established, there's actually loads of help out there and we don't always realise what help there is. So for self-education purposes, the women who feel that they might be going through menopause, the HSE actually has loads of information on their website. So if you put into your favourite search engine, HSE and the word menopause, you will come to the relevant page, and there's lots of information on that. There's also the British Menopause Society have really good resources, and linked with them there is a Women's Health Concern who have brilliant information on their pages and really broken down beautifully into lifestyle measures, medications that we can use, things like that. So of course everybody jumps straight to HRT, and that is incredibly effective for people who it suits, and there are lots of people that can do very, very well with HRT, and the kind you need really depends on other factors, your other health concerns, your family history, things like that. And then there's also non-HRT methods, so what you need and where you go next will depend on your conversation that you have with your physician.
Thank you. And in terms of some of the symptoms that we hear spoken about a lot, Lucy-Anne, bloating, constipation, hot flushes, anxiety and brain fog. Typically, what can be done for those kinds of symptoms for menopausal women?
Okay, so there are lots of things that we can look at. So bloating can be one of the most frustrating symptoms because it can be hormonal and it can be nutritional, it can be lots of things. So certainly looking at hormonal manipulation helps. For some women in the early phases of perimenopause, being on a contraceptive of some sort can help with that. For those later in the process, it might be HRT. Some women will need nutritional advice. It's adjusting fibre, it's exercising. And again, I'm always very reluctant to tell people, go off and exercise or think your way out of this. But actually, in menopause and perimenopause, lifestyle can have a huge impact.
Interesting. And We hear sometimes that anxiety increases during menopause. Is that because estrogen is dropping?
Personally, I think you've hit the nail on the head there. As our hormones fluctuate, we can get these wild swings in hormones during perimenopause that lead then ultimately to low estrogen in menopause. And initially, during that slightly wilder phase, it can be very difficult for women to work out what is going on because their periods might still be normal. But traditionally, estrogen is our happy hormone. So if we're low on it, things might be a little bit harder for us on a day-to-day basis. And progesterone for most women, not all women, is our hormone that's associated with perimenstrual psychology symptoms such as anxiety. So again, if we're having phases of low estrogen, then finally eventually ovulating, releasing some hormones and then making progesterone, it can lead to a lot of those anxiety, brain fog, low mood symptoms with irritability. And I do have women who come back to me when they've started HRT and have found the right combination for them, who say that it's changed their lives, it's saved relationships and things like that. So, we can't underestimate the impact that all of this has on our mental health.
And just going back to constipation, again, is it true that estrogen helps move food through the gut?
That's not something I'm massively familiar with now, I'll have to say. Certainly progesterone is one of the hormones that can lead to changes in gut motility as well. So it's probably just a balance of the two hormones as well as our changing metabolism that has an impact. But I think that's probably more something a nutritionist would need to go into with a patient.
And in terms of if constipation is being caused as a result of menopause and somebody can't take HRT, maybe they've had breast cancer, is something like a laxative something that could help in that situation?
It could be helpful. Again, you need to be sure that the constipation is purely down to menopause or perimenopause and that there isn't another factor contributing. So again, if you've attended your GP and made sure, for example, you don't have a thyroid issue or some other issue that could be contributing to constipation. A lot of us don't actually get enough fibre in our food, and we maybe get away with it when we're a little bit younger, but not so much as we get older. So I think, again, if you're experiencing those kind of symptoms, they aren't necessarily purely hormonal. Get them checked out and make sure you've had the relevant bowel screening.
And that's the point, isn't it? IBS is such a big thing going towards, into our 30s and 40s. IBS is something that comes across in our lifestyle and something that needs to be addressed separate to our hormones.
And so for something like hot flushes, which in the public mind is very associated with menopause, can HRT help with those kind of symptoms?
Absolutely. So the first thing I think to say is that hot flushes are different for every woman. So some people say the word hot flush and they, if I ask a woman, are you experiencing hot flushes? They may say no, but actually they're experiencing an overwhelming heat sensation, almost is what I'd describe it as, that leads to them pausing. They can't finish their sentence, they can't finish their what their task is, or wakes them up at night time. So again, making sure that we're all clear on what a hot flush possibly is for each person. And absolutely HRT can help with that. In fact, it's probably the most effective treatment if you are able to have it. If you're unfortunately one of the women who has had estrogen receptor positive breast cancer, you will be advised not to use estrogen. And then there are alternative methods that I think we're going to talk about in a second.
Great. So Colleen, moving back to you, can women experience bleeding as a result of HRT?
So what we know in this perimenopausal stage is that women can have very abnormal uterine bleeding even before taking hormone replacement therapy. And this needs to be investigated first. And that's what we deal with here at Tallaght University Hospital. We look after women that have abnormal uterine bleeding, and that needs to be addressed first. They could have polyps on their cervix or inside their womb. They could have adenomyosis. So adenomyosis is where the womb gets a little bit larger and this causes abnormal uterine bleeding. We can have leiomyomatas, which are called fibroids. These can be inside the womb, causing really heavy bleeding. Women need to change their pads very, very regularly. So our first line would be to ask the women that have visited their GP is to have an ultrasound scan. This is generally a transvaginal ultrasound scan. This is where we can see a very clear view of the ovaries, assessing the ovaries, seeing at what stage the ovaries are at, making sure they have no cysts, and then also looking for structural abnormalities within the uterus as well.
In addition to that, once we know that there's nothing structural going on, often it's something very simple like just changing the type of HRT, because not all HRTs suit all women, and this is why there are so many preparations out there. The same applies to the contraceptive pill. I think there's around 40 or 50 different types, and that is because no one woman is made the same, and we all respond slightly differently. So it can be a situation where you need a slightly higher dose of estrogen, you need a slightly lower dose of progesterone, or a different way of giving progesterone. So all of these things are usually treatable, but it's important to attend your physician or your advanced nurse practitioner, whatever your access to gynecology services is, so that you can explain your symptoms, let us know, and we can work out how to help you.
That's fascinating. I suppose, could you explain, how does HRT help in general? How does it help a menopausal woman?
I think there's a number of ways. So it's going to help. For our whole body, we need estrogen. We need it in ways that we're probably not 100% aware of. It has beneficial effects on our skin. It has beneficial effects on our hair. It has impacts on our brain. Estrogen on its own, if you have a womb still in place, so if you haven't had a hysterectomy, estrogen on its own will thicken up your lining of your womb. So that's why women need progesterone. Progesterone keeps our lining thin, or it will give you periods if you're not already having them. So that's why we need a combination of both. But really, the majority of the benefit of HRT is primarily estrogen, and the reason we need estrogen to be balanced with progesterone is so that our womb stays healthy. Would that be fair to say, Colleen?
Absolutely. And we are very advocating the Mirena coil in our clinics as part of the HRT, because this works locally within the lining of the womb, and therefore the women don't have to take either an extra tablet, and that would lessen their bleeding and lessen the review of their symptoms of abnormal bleeding with their HRT, which is quite a common thing that we see in our clinics, is bleeding with their HRT. And then someone stops their HRT and they're in a really bad place because all their symptoms are coming rushing back, and the Mirena can stay in for the period of 5 years with their HRT and balance out their hormones.
There are women out there who can't, for whatever reason, be it a history of breast cancer themselves or a very, very strong family history, they may not be in a position to take estrogen relating HRT, and in that case there are next steps. There is a pathway, and it can be a little bit frustrating for women, understandably, because there is no guarantee that any of the next things I'm going to suggest will work for every single woman. And it really becomes a trial and error situation. So you need to have a doctor or a nurse who will go through your symptoms with you, and that you both agree on a time schedule as to how long do you give this particular treatment a trial for, etc. So some of the options are antidepressants. And I know a lot of women get a little bit worried when we mention antidepressants, and I understand that. It's not a doctor's secret way of saying, I think you're depressed and I'm trying to squeeze this medication into you. That's not what we're doing. There are trials and there is evidence in relation to improving hot flushes for women who can't have estrogen. The results are a bit variable. It really depends on the medication and depends on the woman. But the range of improvement is 20 to 50% for each of the different types.
So antidepressants can actually help hot flushes?
They can help hot flushes, and they can also help, of course, if you have a lot of mood or irritability, they can also help that. So there's often a double whammy effect, the very scientific term there. But there are different types of medications. So there's also a medication called gabapentin, and that has also been proven to be helpful in hot flushes. And I would say to a woman, if you can give it at least 2 months on a medication, as long as it's not making you feel horrifically worse, try and give it at least 2 months so that your body can adapt and see whether you like that medication. Some of those medications will not be the right ones for you. Your doctor will know that. If you're on tamoxifen, there are certain antidepressants that you should not take with tamoxifen because they affect its efficacy. But there are other ones that you can try. And then lastly, there is also lifestyle and cognitive behavioural therapy. And again, somebody who comes along to me and says, just think your way out of this, I don't like that. I think that feels dismissive. But when we are given the tools to manage our mental health in the right way, it's incredibly helpful. So there are resources online. There's also through that HSC website I mentioned, if you use your search engine, put in HSC menopause and cognitive behavioural therapy, it will give you links to publicly available services, because not all of us can afford private counselling.
And you seemed to say, and I think it's a really important point, that sometimes there can be a little bit of trial and error in terms of trying to find a solution, and that's normal, but that you should keep continuing to try and find the solution in terms of a medication or another treatment.
Absolutely. I think a good healthcare provider will, first of all, help you with your expectations. Not every single symptom is because of menopause or perimenopause. We will only know what's going to improve when we try a medication and see, do we get you to a reasonable level of whichever, be it HRT or a non-HRT medication, and then we take it from there. Because some of the leftover symptoms may not actually be menopause or perimenopause. They can be something else or made worse by something else, like work stress or life stress, big major life events, those kind of things. So we as well as the patient have to have an open mind as to what's causing these symptoms.
Because, Colleen, it does come at a very difficult phase in the life stage of any woman. She's maybe got a small family, elderly parents. A lot of us are working now. So there's a lot of stress that maybe is or isn't to do with the menopause. Do you find that in the clinics?
Absolutely. We know that this is the time of your life where, you either have teenage children or younger children. They're having their issues and you're trying to deal with that, and then you're working maybe as well. And all these stressors really do impact our lives. And as Luciane was saying, sometimes we need to just step back and look at ourselves and look at how we're feeling and assess that. And journaling is a very good way also of, sitting down and looking at yourself and seeing how things are for yourself.
Some great advice there. Just before we wrap it up, Luciane, anything you'd like to add?
Thanks a million, Nolene. I think that in this world of information, we have it coming at us from all sides. And the minute you look something up on your phone, you put in the word menopause, or even you happen to have ticked a box of an age group, next thing it's all been fired at you. All these TikToks and whatever it is. I sound like I'm not exactly technologically able myself. But the thing is to be sure that the information that you are looking at is reasonably sourced. And it's great that women have access to information, and it's brilliant that women are having this conversation and people aren't hiding in corners, and I think that's fantastic. But I do worry a little bit. It's become very, very popular with influencers and things like that. And influencers can be great in that they can help you get to where you need to go, or give you the empowerment to ask the right questions. But there is also a lot of inaccurate information out there. So I think some of the websites I've mentioned would be really good places to start, and talk to your physician, talk to your nurse practitioner, and you don't have to suffer. There are lots of things that can be done to help.
That's it for our sixth and final episode of this series. Thanks to our experts today, Consultant Endocrinologist Dr. Ann Behan and Colleen Byrne, an advanced nurse practitioner in women's health. Thanks to you, our listeners, and all those who contributed to this series. Don't forget to check out the rest of our podcasts, which you'll find on the Tallaght University Hospital YouTube channel. We're also on Podbean and Apple Podcasts. This Let's Talk About Women's Health series has been brought to you by Tallaght University Hospital. These podcasts have been kindly supported by the Healthy Community section of South Dublin County Partnership. Let's talk again soon.